Let's continue the other causes of allograft dysfunction, right? And we use the formal term delayed graft function when you need dialysis during the immediate post-transplant period. Okay, so hyperacute rejection is something we don't see anymore for the most part because we do cross matches to prevent that from occurring. Acute rejection still can occur. Hyperacute refers to even in the OR, you start to see a mottled kidney because of immediate rejection occurring at the time of the immediately after vascular anastomosis. We'll talk about acute rejections in more detail. We'll go over humoral and cell-mediated rejection. That obviously is a big topic that deserves a separate section within this chapter. Okay, but before we get there, let's round out the other causes of DGF. So AKI or impaired graft function in the immediate post-transplant period. Certainly, you need to think about vascular complications as another category of possibilities that explain allograft dysfunction immediately post-transplant. Most of these occur in that immediate post-transplant period. The living donor transplants appear to have more vascular complications, and that may be because the donor vessels, okay, are shorter. Okay, so you can't take a Corel patch, a piece of the aorta, in order to extend the allograft vessels so for an easier anastomosis into the recipient. And so that makes for a more technically challenging surgery, and so explains why vascular calcifications might be more common in living donor transplants. And I believe I've already said that some espouse, if you have a living donor transplant that does not exhibit immediate graft function, where urine is made in the OR, right? If even immediately post-transplant, if the urine output suddenly drops off in a living donor transplant, some would espouse don't even do an imaging study, go straight to re-exploration for the possibility of a vascular complication, because that shouldn't happen. Some of these are catastrophic and require nephrectomy when you have an acute venous thrombosis. We have a couple of examples of salvaging a kidney in that context, but these are really quite, severe complications. And that's why, again, immediate re-exploration is possibly a right maneuver given the catastrophic complication of losing a kidney. Venous complications are more common than arterial complications. You might see reversal of flow on a Doppler study during diastole as a sign of a venous thrombosis. So you can see that on Doppler. Tenderness is variable because remember, the allograft is, it's not innervated in those first weeks and months of transplantation, and so having graft tenderness is a less common symptom of an acute venous thrombosis. Okay. Urine leak or obstruction is another category of allograft dysfunction immediately post-transplant. Mohammed, I muted you. You can certainly unmute if you have a question. Urine leaks, again, or obstruction, or another cause of immediate post-transplant allograft dysfunction. In some cases, it's really not allograft dysfunction, but rather impaired creatinine clearance that manifests. How do I distinguish those two? Well, it's possible that the allograft function is quite acceptable, but the urine, instead of leaving the body, is spilling into the peritoneum. And so the creatinine, instead of being excreted, is actually getting reabsorbed in the peritoneum. And so again, technically, the allograft is working, it's excreting creatinine. It's just that the creatinine is not leaving the body, it's being reabsorbed by the peritoneum. This leak could be from, it's most commonly because there is a problem with the ureteral anastomosis. This is a particularly delicate part of the transplant surgery. During procurement, there's a great care that's taken to not clip too much periureteral fat, because there's a lot of vascular supply that is hidden in that fat that comes around the ureter. Sometimes you can compromise that vascular supply, and that would be an explanation for ureteral necrosis that might occur immediately post-transplant, or even within that first 2 weeks, where you have, again, a compromised vascular anatomy that later manifests as a ureteral necrosis. We also tie into the bladder. Often that's a really challenging surgical part of, or a very challenging part of the surgical procedure, because especially in patients who make little urine, they'll often have this very kind of contracted, thick-walled bladder that is challenging to make an optimal anastomosis to. It also has reduced compliance, and so you can have a patient who's making gobs of urine into a very small bladder, which is non-compliant, and therefore creates increased pressure on a fresh anastomosis. So many times you'll see the surgeon say, keep the Foley in, because this bladder anastomosis was difficult, so that we don't create tension on that fresh anastomosis, and then take the Foley out, a week later, for instance, when they're taking out the ureteral stents. Or that's not a week later, that would be often a month later post-transplant. Okay, that's a decision that's made by the surgeon. There can be pain. The spillage of urine into the peritoneum can cause a pain that's disproportionate to the surgery. Diagnosis can include renal scintigraphy, where we see actually spillage of tracer into the peritoneum. You'll see the allograft light up, you'll see some of the bladder light up, and then you'll also see this spillage of contrast into a part of the peritoneum that would be unexpected, suggesting again spillage into the peritoneum. Jackson-Pratt drain or JP drain creatinine can also be used as a quick assessment for a ureteral leak or a bladder leak if they left a JP drain in. We've already gone over this concept. All body fluids have a creatinine concentration roughly equal to serum, with the exception of urine. Atherembolic renal disease is another cause of immediate allograft dysfunction. Note, this can be from donor or recipient origin, right? Most of our patients with ESRD are vasculopaths. And so it's possible that the cross-clamping of the iliacs creates a fragility to the atheroma. And after you release the clamps, you shower cholesterol emboli into the allograft kidney. It can also be from the donor if the donor is an older patient with other comorbidities. Okay. Moving on from that early allograft or that immediate allograft dysfunction or DGF to early allograft dysfunction that occurs sort of in this first 3 months, let's expand out the differential further. Acute rejection is still obviously a possibility in those first 3 months. You can still have evidence of ATN that persists post-transplant, and some of our patients are even discharged on dialysis for a couple of weeks as the ATN abates. You can have ATN from overaggressive blood pressure lowering post-transplant, or calcineurin inhibitor levels that are going too high. AIN is also in the differential diagnosis, perhaps to the Bactrim or other agents that the patient is receiving. Obstructive nephropathy can certainly be a concern as ureteral necrosis progresses to ureteral stenosis. Okay, so we look for that. Calcineurin inhibitor toxicity is certainly a big category of causes of early graft dysfunction. Let's move on to others. Lymphocele is another kind of a intermediate term, or let's keep the nomenclature I'm using here. Early allograft dysfunction. Lymphoceles are basically the result of a lymphatic, let's call it trauma, that occurs in the surgical procedure. Remember, as you manipulate the vessels, you have lymphatics that are often in close association and even on the outer surface of these blood vessels. So there's always going to be a compromise to the lymphatic system, and that can result in a fluid collection that is comprised of lymph. This, if it gets large enough, can cause a vascular or ureteral obstruction. And so that can be causing allograft dysfunction. We usually address those with either drainage. Sometimes they're just drained by a needle drainage. It's less common that we leave a drain in because that can be a source of infection. You can actually poke them with a needle and inject a sclerotic agent. And then sometimes they will be addressed surgically by a procedure called marsupialization, if you recall from Bartholini gland, abscesses. You basically need to lance it open and tether the opened fluid collection to neighboring structures in order to keep it open and let the fluid drain into the peritoneum where it's going to be reabsorbed. Okay. So often these are managed by IR once, and then when they recur, the surgeon says, okay, we'll take you back to surgery and we'll lance this open and tether the opening to the neighboring structures, marsupialize this lymphocele. You can develop transplant renal artery stenosis. Okay. Sometimes this is from a kink, really, where the kidney either rotates as the perioperative edema relents. You can get an actual kink, or it can be from trauma to the blood vessel at the time of surgery that results in a stenosis or an imperfect anastomosis, vascular anastomosis. BK can occur during these periods. We're going to talk about opportunistic infections in greater detail later, including BK nephropathy. And then you can also have these recurrent GNs or even de novo GNs. So recurrent FSGS would be an example of early allograft dysfunction that can occur. Let's then go to late allograft dysfunction, and then we're going to segue over to rejection. Okay, let's finish off these again: immediate DGF, early vascular or early allograft dysfunction, and the more late allograft dysfunction. Chronic calcineurin inhibitor toxicity can be recognized histologically through the so-called striped fibrosis. Here's a low power view of kidney biopsy. You can see these perhaps stripes of fibrosis in this core of kidney tissue. The presumption is that this intense vasoconstrictor that calcineurin inhibitors they're vasoconstrictors, result in impaired renal perfusion through segments of the kidney. And when you pass the kidney biopsy needle through those patches of ischemic areas, you get this appearance of stripe fibrosis on that biopsy core. Okay. You'll have varying degrees of tubular atrophy as well, and that can be manifest by these areas of fibrosis. This is a trichome stain. I should just give you a chance to, by through repetition, recognize your stains. This blue and red and is a classic appearance of the trichome stain, where blue stains collagen. And then tubular atrophy can be manifest by dilated tubules with simplified, flattened out epithelium. Okay. Acute and chronic rejection can occur in the late phase. Transplant renal artery stenosis can occur. Remember again, just because you transplant a patient, you're often not resolving the cardiovascular risk factors of the patient. And so they can develop renal artery stenosis in the allograft. I've seen stenosis in the iliacs supplying the kidney transplant downstream. So it's in the recipient, in their iliac vessels, they develop stenosis, and that affects the downstream allograft, even if it's not in the transplant renal artery itself. BK nephropathy can occur in the later phase, again, recurrent and de novo GNs, and then you can again get the old-fashioned causes of kidney disease, hypertension, and diabetes that are recurring in the transplants. Questions before we move over to transplant rejection? All right. Transplant rejection in the modern practice of nephrology or transplant nephrology occurs, or acute rejection occurs in 10 to 15% of patients. And that compares, I think I have it here, or I might have said it in our discussion on immunosuppression, that historically, pre-induction immunosuppression, we would see acute rejection rates that were as high as 40%. Okay, so the use of induction agents has brought down that historical rate of acute rejection of around as much as 40% down to 10 to 15% in the modern practice of transplant nephrology. That might sound like a big gain, but I want to highlight that that also means that presumably 60% of your patients don't need induction immunosuppression. Don't know who those patients are, but it's interesting to think about that. We think about induction as sort of an essential part of immunosuppression, but looked from a different perspective, you can make the argument that 60% of patients don't need induction in order to avoid acute rejections. But again, 10 to 15% rates of acute rejection. Usually these occur in the first 6 months. Okay, those can happen even in the compliant patient. When you see a rejection that occurs, particularly after the first year, you really should be digging deep for non-compliance or inadvertent drops in calcineurin inhibitor levels, right? From a patient, for instance, who was started on rifampin, a P450 enzyme inducer, right? That would drop, your calcineurin inhibitors. Or somebody who was placed on fluconazole, and originally their CNIs were appropriately reduced because fluconazole would raise CNI levels. And then the fluconazole doesn't get refilled, or someone stops it, and then suddenly your calcineurin inhibitor levels are very low. So that would be things you really need to dig for in the patients who have rejections after a year. You really have to challenge, even when patients say, I'm taking my medicine. I got to make big decisions, and I really need the truth so I can make good decisions about what we do next. Okay. Early acute rejections that occur but are reversed quite nicely. Reversed meaning my creatinine comes within 15% of the previous level. Those seem to have less impact on long-term allograft survival. I made that point before because not every allosensitization results in long-term allo incompatibility. Remember, you can recognize non-self, and depending on co-stimulation, the next signals downstream, you can say, I see you, but I'm going to ignore you. Right? That's called tolerance. So again, if you have an early rejection, for instance, if you're using belatacept instead of calcineurin inhibitor, remember we know rates of rejection with belatacept are higher with calcineurin inhibitor. But if you recognize it early, you reverse it, you can say, well, no big deal, right? You had a rejection, but we reversed it easily. So no big deal, right? As long as you catch it early and you reverse it, it may not be so bad for the patient. You might shift towards tolerance, okay? Now, antibody-mediated rejection in general is bad for intermediate and long-term allograft function. Those are generally bad, with few exceptions, okay? Let's now go over to the classification of rejection, starting with antibody-mediated rejection, okay? Now, let's give you the bird's eye view here. We're going to talk about antibody-mediated rejection. Synonym for that is humoral rejection, okay? Some people abbreviate that as AMR, okay? We're going to talk about active and chronic antibody-mediated rejection, okay? So humoral rejection first. We're going to talk about acute and chronic phases of humoral rejection, okay? And then we're going to do the same with cell-mediated rejection. We're going to talk about cell-mediated rejection, acute and chronic phases, okay? That's the overview of what you're going to, what we're going to cover, okay? Think of it in that broad strokes. So it's not just rote memorization. Humoral and cell-mediated rejection, acute and chronic, okay? So acute antibody-mediated rejection, how do we define that? Well, all three of the following must be present. I should have histologic evidence of acute injury, okay, with either TMA. So let's start backtracking here. If you have TMA on a kidney biopsy, one possibility is that's a manifestation of acute antibody-mediated rejection. It also could be calcineurin inhibitor toxicity, right? Or it could be malignant hypertension, or it could be a recurrence of atypical HUS, right? Those are all possible explanations for a thrombotic microangiopathy. Again, AMR is one of your differential diagnoses. Remember, RAPA can do this as well. So, of a thrombotic microangiopathy. Okay? ATN with no other explanation. That's unsatisfying, but it's in his list of possibilities of histologic evidence of AMR. The more common thing that we see is the so-called peritubular capillaritis and glomerulitis. So these two things aside, this is where your attention should be. Peritubular capillaritis and glomerulitis. What is peritubular capillaritis? It takes some orientation. You see lumens or lumina, I guess is plural for lumen. Okay, you see lumina in your tubular interstitium. How do I tell if that's a tubular lumen or a capillary lumen? Well, tubular lumen have at least a cuboidal or more columnar epithelium, right? If you see a lumen which is very flat because it has only a flattened endothelial cell, you say, okay, that's a capillary lumen. Normally, capillary lumen should look almost invisible. Right? That is a capillary lumen too. That's how a normal capillary lumen. However, if you have lots of inflammatory cells in this lumen, this is big. You say, is this a tubular lumen? No, it's a flattened endothelium. This should be a peritubular capillary that's filled with inflammatory cells. This is peritubular capillaris. Okay. The other thing, again, is glomerulitis. What is glomerulitis? Well, it's a glomerulus with endocapillary hypercellularity. We've gone over that in Puja's lectures, right? Endocapillary hypercellularity. That's a non-specific finding on light microscopy. What else can cause endocapillary hypercellularity? Recurrent lupus, infection-associated GN. Well, how do I distinguish glomerulitis from recurrent lupus nephritis? I look at my IF. I look at my EM, right? So by light microscopy, this can be recurrent lupus nephritis. Glomerulitis, even though it has a specific name, it's nothing but endocapillary hypercellularity in a transplant patient that doesn't have an alternate explanation like recurrent lupus. Okay? Everybody get that?
And lupus though?
No.
Okay.
Yeah. But you don't need both. So the question is, do I have peritubular capillaritis in lupus? You typically will not. But you don't need both. I can have or glomerulitis, and that be sufficient for these histologic features of AMR. Okay. All right. So that's one of the three criteria you need to make the call of AMR. TMA, ATN, PTC, or glomerulitis. Okay. And then you need evidence of antibody interacting with endothelium. Okay. Which includes C4D staining in peritubular capillaries. That's the most common thing that we're going to see. If I have severe PTC or glomerulitis, we say that's sufficient as well. Okay, that's evidence of recent antibody interacting with endothelium. Kind of subjective call, as you can tell, right? Usually we're relying on C4D, right? So the more common things I'm highlighting are the histologic evidence. The more common things you're going to see are PTC. The second criteria is going to be positive C4D. What is C4D? I guess I glossed over that. Remember, C4 is a complement component that is a part of the classical pathway of complement activation. C4 is part of classical complement activation cascade. Okay. C4D, if you remember your nomenclature, is a fragment. It's a cleavage piece of C4. So all these C4, anytime there's in the complement nomenclature, if there's an A, a B, a C, a D, these are all just pieces of the mature whole complement component. Okay, C4D is a piece of C4 that is covalently bound to cell surfaces that have interacted with classical pathway of complement activation. Okay, so that covalent binding gives it resilience, right? Gives it persistence on kidney biopsy specimens. Okay, so that's why we often see C4D, and that can persist for a while. Okay. The third criteria is we need a positive donor-specific antibody. Remember how we measure donor-specific antibodies? That's the Luminex study, right? You order it as HLA antibodies. Remember what's the difference between an HLA antibody and a DSA? Finish, you remember that? What's a HLA antibody? And what's a DSA antibody? You order the same test for both. On the one hand, you say, yes, you have HLA antibodies. On another hand, you'll say, oh, no, you have D donor specific. Well, antibodies are not coming from the donor. They are coming from the recipient. What is specific about a DSA? How do you distinguish HLA from DSA? HLA antibodies from DSA? Okay, let me represent this graphically. Think of a Venn diagram. The bigger population is HLA antibodies, okay? You are now producing, you may be producing antibodies to an A2, a B11, a DR, okay? So again, if we're thinking in terms of Venn diagrams, I have HLA antibodies that I may be producing, only some of which are donor specific. What makes these donor specific? Sophie? What makes this HLA antibody donor specific? Free for all? Anybody? Loud, confident?
That is specific. He's expressing that.
Yeah.
So
Yeah. So I may be producing an anti-A2, but if my donor doesn't have an A2, it's just an HLA antibody. If I'm producing a B11 antibody, but my donor has B11 on it, it's donor specific. Christelle, you get that? Okay. Right, you've seen either thinking about this or something else.
No.
Yeah. Okay, so that would be a third criteria that you're looking for AMR, donor specific antibodies, not just the HLA antibodies, donor specific antibodies. Everybody get that?
that's what I was.
AlloSure is different. AlloSure is the same thing that new parents ask for to know the gender of their baby early in pregnancy. They're looking for cell-free DNA. The name says it all. There's DNA floating outside of a nucleus in your blood. And if you can sequence that and compare it to known DNA from the mom and dad, you can tell that this is, well, you only need to compare it to mom, not to dad. You can tell that, oh, you have another, human inside you, and you can also say, oh, they have an X chromosome. Okay? You're doing the same thing with AlloSure, looking for non-me DNA that's circulating in my blood. That must have come from something, presumably that's from an injured allograft. Okay? Really not a good test. That's the summary. Not a good test. You can have, as you can imagine, if I have a severe ATN, maybe that'll cause cell-free DNA that I can detect. Anything that injures your allograft, you would expect. I bet that can cause cell-free DNA. The best evidence or the best correlation with rejection is in AMR. It's a really crummy test for T cell rejections. But even within the subpopulation of AMRs, they're not. Yes, question?
Why CD4D stain on glomerulitis doesn't count as a criteria?
C4D, the question is, why does C4D staining in the glomerulus not count? It's an answer that's perhaps not that satisfying. C4D staining in the glomerulus is almost universal. Okay, so it doesn't track with rejection. In fact, C4D staining in the glomerulus is often used as an internal positive control to make sure that your C4D is staining is believable, right? If I have a negative C4D, but my glomerulus is also negative, you say, I'm not so sure this was a good C4D stain. Okay, so C4D staining in the glomerulus is pretty much universal in post-transplant biopsies. Okay. You can ask yourself, well, why is that? Why does that not correlate with, organ dysfunction? And you'll go into a rabbit hole. Let's just take it on face value, okay? All right, so treatment, okay? Obviously, again, this is variable according to the transplant center. Many transplant centers look for donor-specific antibodies and they titer them, okay? That is all, again, qualitative tests. And so the units of measurement for our lab is mean fluorescence intensity, MFI. They give you this, this arbitrary unit, mean fluorescence intensity, and they give you a cutoff. In our lab, MFI greater than, 800 is considered strong, something like that. I don't know what off the top of my head but you'll see it in the reports too. Okay. And then during treatment, we'll retiter. We'll see if that DSA is becoming less intense by MFI measurements. Okay. We often give corticosteroids. We're often doing plasmapheresis. Okay. Usually it's every other day. We had a pheresis talk yesterday. Our pheresis attending also said sometimes we'll do back-to-back pheresis in the first 2 days and then go to every other day because you get diminishing returns if you just keep pheresing back to back to back. Okay, remember, because the antibody has limited intravascular distribution, especially the IgGs. She mentioned IgM has a 75% intravascular distribution because it's a big molecule. Most allograft dysfunction is driven from IgG. Okay, so she said 45% of IgG is intravascular. So that's why, again, going back to back to back is not all that helpful. So every other day is typical. We often give a little bit of IVIG afterwards. I don't think, I know Andrew and I think it was Priscilla, you and Andrew were asking questions about IVIG in FSGS patients. And I told you, post-transplant FSGS doesn't make much sense to give IVIG in pheresis for post-transplant FSGS because it's not driven by an immunoglobulin. And I suspect the protocols that are used are just translations of things that transplant nephrologists do, including managing tumor rejection. They typically give IVIG post-pheresis. And I told you and Andrew, what you're trying to do is try and avoid the post-pheresis rebound antibody production that might occur. Okay. Plasma cells, this looks like an antibody. I should have made it look a little different. Okay, have FC receptors on them. Okay, and so when you pherese a patient and there was antibody circulating, but you reduce that circulating antibody, that plasma cell can see that and say, oh, let's make more antibody. Okay, through those FC receptors. So by freezing someone and then giving them other immunoglobulin through IVIG, you try and limit, presumably, this is my mechanistic understanding of the rationale of post-transplant IVIG administration. You're trying to block that rebound increase in DSA production. Okay? But you don't want to give all your IVIG. You don't want to give all your IVIG and then freeze it again, freeze it off with the next pheresis. So we give a little bit of IVIG. A full dose IVIG is somewhere around a gram to 500 milligrams per kilogram for each dose. You know, if you give 4 doses of 500 milligrams per kilogram, that would be a total of 2 grams per kilogram. You can certainly also reasonably safely give a gram per kilogram at a time for the full dose, so 2 doses of a gram per kilogram. That would be your quote unquote full dose IVIG. So many times you would say, okay, let's do pheresis every other day, 100 mg per kg times 5. That would be 500 mg per kg. And then I'm going to give you 500 mg per kg times 3 more doses after pheresis is done to fill your tank. Okay? Everybody get that? In addition, so steroids, pheresis, IVIG, and then increased maintenance immunosuppression. Okay. Thymo can be given if there's often a concomitant cellular rejection, which is often the case. Okay. Pure humoral rejections can occur, and we would typically hold back on our thymo in that scenario, but there can also be overlapping humoral and cell-mediated rejection. Now that makes for even more complexity as you're thinking about pheresis, right? Pheresis every other day. When do I sneak my thymo in? I don't want to give thymo and then freeze it off, right? So it makes for often a long and puzzling strategy of, well, pheresis today, IVIG that day, thymo later. If I gave thymo, I probably don't need a lot of IVIG at the end, right? What is thymo? It's a bunch of immunoglobulin, right? Immunoglobulin that a rabbit, made to human antigens, right? Okay, that may not be so great at blocking plasma cell immunoglobulin production, but again, you get into sort of tangled, strategy once you're trying to give all this stuff and take away stuff and not block stuff. Okay. Rituximab, eculizumab are also in these treatment protocols. You'll see in various transplant centers. Remember, eculizumab is expensive and it's hard to get insurance approval for that's off-label use. Like very expensive. $500,000 for 6 months. That's expensive. All right, chronic AMR. Okay, we talked about acute AMR. Now we're talking about chronic AMR. How do I diagnose it? Again, 3 criteria. Histologic evidence of chronic injury. What are those signs of chronic injury? Transplant glomerulopathy is one of your differential for this finding. Okay, should be thinking of Kelly or your messaging Kelly, so I can't pick on you. Okay. If I have this finding, what does my mind think of? What in a non-transplant patient?
Doubling the duplication.
Okay, chronic TMA, that's a good one. Okay, anything else? What is this? This has a name. This is silver stain. Free for all? Double contours. Yeah, basement membrane reduplication. Yep, basement membrane splitting. All of those should bring to mind MPGN as a potential membranous spikes, right? So here's now some logic to think about, okay? How do all of these things, how can they all kind of fit together, right? MPGN, TMA, chronic humoral rejection. What do they all have in common is what you should be asking yourself, such that all these various diseases can manifest with this. Anything that causes chronic endothelial injury can create this histologic feature of disordered basement membrane structure. Okay. So think anything chronic endothelial injury. Okay. So transplant glomerulopathy. Remember, AMR is often, you have peritubular capillaritis. That's showing you that there's a immunologic response to the endothelium, right? So again, you can envision that results in a disordered glomerular basement membrane, okay, that is manifest by slitting. Thrombotic microangiopathy, right? A lot of endothelial injury. In the chronic phase, you can see this GBM splitting. MPGN, the classic cause of MPGN is C3 glomerulopathy, C3GNs. This is disordered complement regulation, which you can envision causing endothelial injury, chronic endothelial. Okay? So anything chronic endothelial injury that you can think of would be a potential explanation. You can see this even at the late stages of antiphospholipid antibody syndrome, which is often also can cause TMA. Okay? Everybody get that? Okay. The other histologic evidence that you're looking for, peritubular capillary basement membrane, multi-layering. It's an EM finding, okay? This is your most specific finding for chronic AMR, okay? Remember, this is in the peritubular capillaries, not in your glomerular capillaries, although you can often see similar GBM alterations in glomerular capillaries. This is peritubular capillaries, right? So this is a classic appearance of this multi-layered glomerular or peritubular basement membrane. And again, that should make sense to you, right? I just told you chronic endothelial injury causes this disordered basement membrane synthesis. We showed, peritubular capillaritis, there's clearly inflammation involving the endothelium. Of course, we should expect some abnormal response of the endothelial cell to that chronic injury. Here's one of the most specific findings, the peritubular capillary basement membrane multi-layer. Okay? You can see in the arteries, intimal fibrosis. Okay, that's a non-specific finding. Intimal fibrosis can be, changes that you see from chronic CNI toxicity. Hypertension can do some of that. There'll be medial thickening, medial arterial medial thickening. So this is a non-specific finding. Really, this is the most specific finding. This has reasonable specificity. This is the least specific finding. Okay. I want to see again evidence of recent antibody interaction with the endothelium, which is present, which is again moderate to severe PTC or glomerulitis, right? Or C4D positive immunofluorescence. Okay. And then I want DSAs present as well. This is chronic AMR. Treatment protocols differ. We have this enthusiasm for treating with antiplatelet agents and hypertriglyceridemia because there's some correlation with worse outcomes with severe dyslipidemia. Whether this helps your patient or not is unclear. We, of course, treat hypertension. Take that out. We treat everybody's hypertension. Intensify maintenance immunosuppression. Increase prednisone to 10 is often something that we do. some people will try and lower the DSAs with IVIG. Most people will not freeze these folks. For chronic AMR, you just try and suppress DSA production through the administration of IVIG. Okay, let's get through TCR, even though we're kind of rounding at the end, because that's a natural stopping point. Okay, TCR, again, acute and chronic. Right? Nothing surprising there. TCR has a classification system that you should know, comes up in questions, and it's part of the conversational clinical decision making that is common in transplant methodology. Okay, so you have to know what these things mean. This is rote memorization. You should invest the time to remember the scoring system of TCR. Okay, I do not think you need to memorize the correlates of the TCR and the IFTA. You'll see all these scores in a transplant biopsy. You'll see PTC scores, which is scoring the degree of peritubular capillaritis. You'll see glomerulitis scores. You'll see tubulitis scores. They'll have all these T1, T2, T3s. Don't waste your time. Nobody's going to ask you questions about that. But you do need to know what's a 1A rejection, what's a 1B rejection. Those you should invest the time on memorizing. Okay, what is tubulitis first? Tubulitis took me a while to sort of get my mind's eye tuned to this. Okay, you have to be able to recognize a tubule. Okay, here is a PAS stain. Here's an epithelium. This is a tubule as well. Okay, this may be a peritubular capillary. Right, here's a tubule. Okay, if you see a big nucleus, often with a visible nucleolus, that is a tubular epithelial cell nucleus. This is a distinctly different cell. It's got compact nucleus, much smaller, dense, dark. That is a lymphocyte. Okay, that is peritubular tubulitis. Okay, when I have lymphocytes that have passed beyond the tubular basement membrane, that is tubulitis. These are, again, lymphocytes, very different from the tubular epithelial cell. Okay, all right. If it involves, if you see, you score based on a cross-sectional tubule. If I got a tubule that I sectioned long way, as you can imagine, you'll have a lot of surface area to start counting lymphocytes, which is unfairly biasing this score. Okay, so the number of lymphocytes that you can see per tubular cross section is used to make these scores of peritubular capillaritis. But again, we look at tubules that are sectioned perpendicular to their long axis, right? So this would be a reasonable one to count. Okay, we're not looking at the tubules that are, long way. I happen to section it across its long axis. Okay. If I see tubulitis, but it's involving less than 25% of the total surface area of the kidney biopsy specimen, I will call that borderline rejection. Okay. If I see greater than 25% of the surface area involved, that's when I begin to call it 1A, 1B, or 2A. 1A or 1B. Okay, the twos go into arteritis. All right, so again, I'm looking for greater than 25% parenchymal involvement. Okay, before I'm calling it anything but borderline. Right? If I see 5 to 10 of these per cross section of a tubule, then I'm calling it a 1A. If I see greater than 10, I'm calling it a 1B. Usually for these 1As, I'm using steroids alone. Okay. We have mini pulses and maxi pulses, which I don't have memorized, but some steroids, okay? If it doesn't respond, or if you have more aggressive rejections, you start thinking about thymo. You can use thymo for a 1A rejection if it doesn't respond to steroids, okay? But if you have more severe degrees of tubulitis, that's when I'm proactively using thymo, okay? Plus steroids. Okay. Sometimes, again, we're still treating only with steroids with 1Bs and then pulling out the thymo if there is no response in the initial days of steroid pulses. Okay? Almost there, almost to the end, stay with me. The 2A, 2Bs, and 3s all involve arteritis. Okay, once I cross the threshold of arteritis, I go from 1 to 2. Okay, A, B, and 3 are now what we have to define. Okay, we are using this time not a tubule, we're using an artery to make a determination of arteritis as opposed to tubulitis, as the name implies. Okay, and we're using the lumen, okay, the luminal encroachment to determine whether this is 2A or 2B. If the lumen, if the encroachment on the lumen, right, these are a bunch of inflammatory cells that are lifting the normal intima. This is the intimal layer, right? The flattened endothelium. These are your muscular layers of this blood vessel. This is intima that has been lifted by all this inflammation. Okay. All right, so I have more than 25% of my lumen being lost. This would be a 2B rejection. Okay. So if I have less than 25%, it's a 2A. Usually when you have arteritis, that's bad. We're pulling out thymo up front. Okay. For 3, I'm seeing inflammation across all 3 layers. Inflammation not just in the intimal layer. I see inflammation extending into the media and the adventitia even sometimes. Okay, that would be considered transmural arteritis, making it a 3. Right? If I see necrosis of the vascular wall, that also makes it a 3. Those are bad. Okay. Chronic active T cell mediated rejection is a more fuzzy diagnosis. I'm seeing intimal fibrosis. Okay. Remember, intima should be pretty non-distinct. The intima and media are pretty much, juxtaposed. Once I see the intima being lifted by an acellular matrix of pinkish stuff, that's intimal fibrosis. I'll tend to see some infiltrate, not just bland fibrosis like hypertension you might see, or chronic CNI toxicity. When I see inflammation plus that intimal fibrosis, then I'm making this chronic T cell rejection. Okay, and there's a grading scale. I don't have it memorized. You won't be asked it. Okay, we also grade IFTA. I don't have this memorized. It's mild, moderate, and severe. Okay, that helps you determine what is the long-term consequence of this allograft injury. Questions about rejection? Right. Let's end it there then.